right, let's talk about something that's a little bit different. We really don't talk about ribs very often, and rib fractures, rib injuries. It's not something that we see a lot. Fractures are usually not surgical, so it's rare that you're going to see a fixation of a rib fracture. Most of the time in the U.S., you don't even see them for therapy. It's rare to see them for therapy because doctors will usually just say, okay, you fractured a rib, just be a little bit careful and move when you feel like you can move, and most people are fine. So this is not something that is a common non-operative or post-operative issue, at least in my experience. But I have seen some patients after rib fractures in China. I have seen some complications from rib fractures in China. So it's definitely something that you need to be aware of and know how to work with. So reminder of our anatomy, we have 12 sets of ribs. Bottom 2 are usually floating, so they're not attached to the sternum. And really, you can see even like 9 and 10 are kind of indirectly attached to the sternum, right? So just as kind of a reminder, that first rib is above the clavicle and is pretty easy to palpate from superiorly to inferiorly. And just looking at the ribs, the head and neck and tubercle are all going to articulate with the vertebrae. Okay, so that's actually the posterior aspect of the rib. And then you come around to the body of the rib angle, and then the costal groove, and then that area on the bottom is where it attaches to the sternum. So you can see here that where the rib attaches to the vertebrae, that there's multiple areas of articulation. So you'll see the articular part of the tubercle of the rib is really at the most kind of lateral transverse process area. And then it also articulates at the head of the rib to essentially what's called the superior demifacet, or this area that's closer to the body of the vertebrae. So ribs really have a good amount of influence on the vertebrae, and the vertebrae have a good amount of influence on the ribs. And so when we think of manual therapy, when I teach this stuff to therapists, mobilizing the thoracic spine can really make a big difference with rib mobility. So you definitely don't want to just mobilize the ribs themselves, but consider thoracic mobility and mobilization to provide a lot of improvement for rib mobility. And that's rib mobility along the posterior aspect, the lateral aspect, and even the anterior aspect of the rib. So movements of the rib cage. We think of the ribs, the top ribs, moving a little bit differently than the bottom ribs. So like the top half, the upper ribs, move more like what we call a pump handle. And so they're actually moving more anterior and posterior and superior and inferior, whereas the lower ribs are more like a bucket handle. So they're actually going more lateral and superior and lateral and inferior. So those movements are different, and that's going to be important when we're thinking about how to improve mobility and when we're helping instruct patients on breathing. So fractures are usually occurring in the ribs with some sort of blunt force trauma. So this could be a fall, this could be a car accident, a scooter accident. A lot of the times these patients will have something else that's a bigger problem and that your therapy might be focused on. So if they had a really bad car accident, then they probably fractured some ribs, but they also might have fractured, their collarbone, their clavicle, and, their foot or something like that. So you're really focused on those things because the ribs are usually going to heal pretty well. There are other reasons why you might get rib fractures. If there's some sort of metastases, like some sort of bone cancer, osteoporosis could lead to rib fractures. If somebody coughs really, really hard and they're already osteoporotic, that could lead to rib fractures. Or if they have a fall, then that obviously could lead to a rib fracture if they have osteoporosis. So just what I just said, stress fractures of the ribs can happen if there's a lot of forceful coughing, or you could get a stress fracture with highly repetitive movements. So especially kind of like movements where they're moving the scapula a lot or they're doing a lot of rotation. So people like rowers, pitchers who have to do that throwing position, golfers where their arm again is moving kind of down their trunk or their thorax and doing that rotation at the same time, you may end up with some stress fractures. Complications. So complications are usually what will lead patients to needing surgery, right? So hemothorax, pneumothorax. So pneumothorax, this is where you have that collapsed lung. So this is actually a picture of pneumothorax where the lung is not expanding like it's supposed to, and it's not holding any pressure. So you're not getting the alveoli to take in oxygen. If that is true, signs and symptoms of a pneumothorax would be that their fingers, their toes, their lips might be blue. And again, they're usually having some shortness of breath, things like that. So we rarely are going to see patients in an acute situation where they may have pneumothorax from a rib fracture, but just keep in mind that those are symptoms that if they're breathing funny and they say they fell, so you might think that maybe they punctured a lung, which is what that is, and that collapsed lung, so they're not able to get oxygen on that side of their thoracic cavity. Separation of the costochondral junction. So that could be where you literally have the rib, like a separation between ribs, and then you end up with like issues at the sternum or possibly even issues posteriorly. So rib fractures, they say about 10% of all traumatic injuries are rib fractures. So yeah, it's a pretty common problem, but again, we're usually not seeing them for rehab. The ribs that are most likely going to be fractured are going to be ribs 5 to 9. And it's usually where at the posterior angle. So just as the rib is coming around to the back, this is the weakest point of the rib. And so it's most likely where you're going to get your fracture. So thinking about other things that might be involved. So again, if it's a bad enough fracture, they may choose to do surgery. And because we're looking at, is there other tissue? Are there other organs that might be affected by the rib? So for instance, if the left lower ribs have a fracture or an injury, then there could also be an injury to different organs like the spleen. So not the lungs themselves, but you could end up lacerating the spleen. The right lower ribs, this is where the liver is, so you could end up with injury to the liver. And then with the floating ribs of rib 11 and 12, this is where you could end up messing up with the kidneys. So the kidneys could have injuries if those ribs 11 and 12 are injured. So again, this is not something that you have to be necessarily like diagnosing, but recognizing that if there was an injury to that area and they're starting to complain of other injuries, other issues like, I'm having trouble urinating, or my urinating is my urine is a funny color or something like that, then you want to consider the fact that maybe there was an injury to, in that case, the kidneys. If you hear that a first rib was fractured, that's going to be a major trauma. That's going to be a big, significant problem, because usually the first rib, if you think about the anatomy of it, it's protected by the shoulder, the clavicle, and the lower cervical muscles. So all these things should stabilize the first rib. The scalene's all attached to the first rib. So this is just showing an awful picture of the first rib being fractured. That means that if there's a first rib fracture, there's probably more likelihood that they will die. So mortality rate is as high as 36% if there's first rib fractures. So again, there's probably a lot of other stuff going on. You're rarely gonna see a patient who just fractured their first rib. And if you do, that's gonna affect their thoracic outlet. So that's gonna affect all the nerves going down. In this case, this is a picture of the right arm. So this would affect all the nerves and sensation down that right arm, as well as a lot of other possible complications. So first rib fractures are much more challenging than just the rest of the ribs. So diagnosis, history of trauma, history of something. If they had a chronic cough or they have that osteoporosis, then you might be thinking about other things, but there might also be, a history of cancer or something. So you're thinking that there could be metastases of that cancer into the ribs. The big one that we are looking for, you're going to say this is probably ribs, is going to be painful breathing. So especially with inspiration, and we're going to talk a little bit about the breathing techniques. I have a couple of videos for breathing techniques. With inspiration, our ribs the top ribs are going to go out and up, and remember the bottom ribs are going to go laterally and up. And so it's that motion that usually would cause pain if there's a rib fracture or some sort of rib injury. You may also see what's called paradoxical breathing. So paradoxical breathing, when we breathe in, we should breathe in and open up through the lungs and expand through the stomach. When we breathe out, we should close through the lungs and the stomach. But this is paradoxical breathing, is where the segment moves in. So it does the opposite of what it's supposed to do with inspiration, and it moves out with expiration. So just at the area where there might be a fracture, it's not going to move the same way. It's going to do the opposite of the normal movement. Unfortunately, x-rays are not incredibly sensitive of rib fractures, so about 50% of them are missed. So again, if you're suspecting, especially if you think there might be complications like pneumothorax, then I would say, if they've taken an x-ray, maybe have them take another one or do an MRI or something to make sure that they've ruled out rib fractures that could be affecting, again, other organs. That's the most important thing, because that's where they may need to do surgery. So this is a good example of if there's a rib fracture. That's kind of the paroxysmal breathing that I was talking about. So when you're breathing in, it's collapsing actually during inspiration. So it's getting smaller in that area where the fracture is. And then as you're breathing out, it's going out. So again, this is what we don't want. We don't want to see that with their breathing. So most of the time, rib fractures are going to be managed conservatively, okay? Unless there's something else wrong and they have to go in and fix the ribs and maybe the lungs or the kidneys or the spleen or the liver or whatever. If that's true, this non-operative treatment is really about pain control. It's going to look a lot like the post-operative treatment. We're going to kind of teach them how to brace when they cough, teach them, how to basically do pain management with something like TENS if they want to, but then also telling them that it's okay to move. So we're going to go through some different movement patterns and things, and we're going to go through respiratory exercises here as we talk about post-operative. These things are very important for the non-operative patients. Again, the rehab is going to look very, very similar for both. For non-operative treatment for stress fractures, so basically if they're an athlete, so if they're a younger person, like we talked about, the pitcher, the swimmer, the rower, then they basically just say, take this time off. We're going to talk about stress fractures of the lower extremity in another recording. And they basically just say, take 4 to 6 weeks off and then start to go back to your activities a little bit slower after that. So get back into your normal things, obviously looking for problems with movement patterns and things like that so that you don't end up with another stress fracture. However, most rib fractures are stable in 1 to 2 weeks, and they're completely healed by 6 weeks, okay? Rib fractures are fast because there's a lot of blood flow in that area, right? Because it's right around all of our organs. So rib fractures really are not too much of a big deal, as I've said several times now. 93% of all patients with rib fractures by week 6 are back to their normal activities, okay? So that's what the research tells us. We should not be seeing a whole lot of issues with this patient population. However, they will choose to do surgery if there's a malunion. So if the ribs were not lined up correctly after the fracture, or if there were the other complications that we've talked about. Here's a picture of what the surgery will look like. So you can see here on the left, those are just these little, they're almost like little staples. They're little, rings that can go around each individual rib to stabilize it. So that's usually what they'll look like. And again, you'll see from these pictures that it was multiple ribs. It's not usually just one rib, because it's multiple ribs that are going to affect the organs in the thorax. So our treatment for the first couple of weeks is they're not being that conservative with these guys. We're going to teach them, like I said, how to splint, how to be a little bit more careful during coughing or sneezing. But really, we want to get as much functional mobility, even during this first phase, as we can. We want to improve tidal volume, so that's the lungs. We want to make sure that as soon as possible that those patients are getting full inspiration and full expiration. One of the ways that you can help with that is what's called incentive spirometry. This is a picture that's here. So what this does is it gives the patient kind of biofeedback to show them that they're taking a good inspiration of the breath. So they're opening up their lungs, they're letting the ribs move up or out or both. And an incentive spirometer is going to have either little balls or a little something that moves up and down. And so they put that around their mouth. They suck in inspiration. And when they do that, if they get enough, then it's going to show them, again, that biofeedback, it's going to show them that they're expanding their lungs. They're opening up their rib cage. So that's a nice way to make sure that they are getting the breathing and doing breathing correctly during this first phase. You also just want to be doing early mobilization. So again, recognizing that the thoracic spine is attached to the ribs, you want to make sure the thoracic spine is moving. So they can get up and move. They can do bed mobility. You can work on transfer training. You can work on gait training. All of those things as early as possible is good, okay? TENS unit for pain, totally a great idea as well. So again, here is a picture, and I'm going to show you some video of what this can look like. So again, as we inhale, those the lateral ribs, the lower ribs are going out, the top ribs are going kind of up, and the diaphragm is contracting. So you're going to see, hopefully, you're going to see the stomach kind of get a little bit bigger. And that's really what we're looking for when we inspire for inspiration, and then for expiration, everything comes back in and the diaphragm relaxes. This movement should be happening through all parts of the trunk. So if you're just seeing the neck moving or the upper ribs moving, then they're not getting good expansion in the lower lungs. They're not getting full expansion of all lobes of the lungs. You can still use the neck, but only for big, deep breaths. If you're seeing neck movement all the time with breathing, then they're not expanding through their lungs. They're not doing any other type of breathing other than neck. So we're going to need to instruct them on their breathing. And so I'm going to show you 2 videos. We're going to show you this first one first. This is a patient in supine. This patient actually had a spinal cord injury, and there's an interpreter here, so we shouldn't need any anything written down below for this one. Subtitles, we don't need subtitles. This patient, I was just teaching how to breathe for the first time. He actually does a pretty good job of breathing through his diaphragm and doing stomach breathing. So here's just a quick video of that. Okay, so I want to talk about how to breathe the right way after your injury. So the goal is that we're breathing down low. We call this abdominal breathing, or sometimes diaphragmatic breathing. So the goal is, what you want to do is breathe in through your mouth or your nose and expand in this area. And to get to all parts of the lungs, you're going to really want to open it up and count while you're doing it.
对，就是吸气的时候，吸到那个肺里之后呢，你要进行数秒，读秒。
So we're going to breathe in, 1、2、3、4、5, and then breathe out, 1、2、3、4、5、6. So one more out, really getting all that air out to allow for air to come in.
对，吸气的时候吸5秒，吐的时候吐6秒，就是保证你吐气的时候要比吸气的时候多1秒。
So let's try that.
我们试一下。
1、2、3、4、5。1、2、3、4、5、6。
对。Okay, so that can be kind of first stage. Again, we don't want patient laying down for a long period of time, but if it's easier to teach them breathing in supine, that's fine. Really, if they can sit up, the earlier they can sit up to practice. Anytime you learn about breathing techniques for patients, who maybe have a cardiopulmonary problem or COPD, something like that, or when you just talk about relaxation breathing techniques, they'll usually suggest that you do it in sitting or even standing because it allows for a little bit better expansion of the ribs. So I'm just showing you the supine version. I'm going to show you another sitting version of showing real rib expansion here in just a little bit. But that's fine to start off with them in supine if it's just easier to teach them the technique. So phase 2, starting at week 2. Again, this is pretty fast stuff. So just for a couple of weeks, we really want to continue focusing on vital capacity, so getting those lungs to work well. And then we also want to improve motion. So you could be doing some mobilization and stuff, and we'll talk about that. But we also want to think about thoracic spine extension and flexion. And I'll show some pictures of that as well. But when we go into extension and we want to allow for some rotation with that extension, then that helps to, again, open up the lungs even more and get the ribs to separate themselves a little bit more. So we'll go through the breathing techniques again. Diaphragmatic breathing. Again, I would say breathing through your lungs. So yes, diaphragmatic breathing is awesome. We tend to forget how to do that. So we all did that as children. But then as we get older, we kind of change our breathing styles, some of us. And so kind of relearning diaphragmatic breathing can be good. Segmental breathing, this video is going to show that a little bit, doing breathing in different parts of the lungs and using different parts of the ribs. You can certainly use NDT principles to get that expansion. And I kind of do like a dong tai song dong to kind of work on that expansion as well. Again, if we have a chance to do a lab class for these, we can certainly go over that. And then making sure that their treatment, that they're keeping up their cardiovascular conditioning using whatever, stationary bike or walking or whatever. And then I would also add to this, you can do manual therapy techniques of the thoracic spine. Most of the time, they're not going to tolerate prone positioning, so you end up doing those thoracic mobilizations in side lying. But those thoracic mobilizations can sometimes help with pain control. So I'm just really gentle doing that level wherever the rib fractures were, just gentle PAs in side lying. So let's watch this video. She's going to show you some different ways. This one is just in English, unfortunately. She's going to show you some different techniques and different ways of kind of opening up your lungs with breathing.
Abdominal breathing, or three-dimensional breathing. So it can be helpful to place one hand on your chest and the other hand on your abdomen. And so to begin, we start by breathing into your abdomen, pushing it outwards on your inhale. Exhale, just allowing your abdomen to soften and fall away. Try that once more. Inhale, expanding the tummy. And exhale, soften and fall away. Now try adding the chest. Inhale abdomen. Then inhale chest. Exhale chest. Exhale abdomen. Once more. Inhale abdomen. Inhale chest. Exhale chest. Exhale abdomen. Beautiful. And relax. For the last part of this technique, add the side ribs. So it can be useful to take your hands and just gently place them on the side ribs. So we'll inhale abdomen, inhale chest, inhale side ribs, exhale ribs, chest, abdomen. One last time. Inhale abdomen, inhale chest, inhale side ribs. And then exhale, 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 and release. I'm Jennifer Taylor. Thank you for watching and stay well.
Okay, I do really like that breathing video. I think she does a good job of showing you kind of the different ways to do it. So again, I would say it's helpful to take a hand like she did and place it in the area where you're trying to get the expansion to help kind of stimulate it. So depending on where the fracture is, you could have them put their hand there and say you want them to sort of expand into that hand. I think that can be helpful for when you're retraining breathing. Okay, so last phase, functional phase is going to be starting around week 4. And we're really emphasizing that ribcage mobility. If there are any soft tissue restrictions intercostally, so like in between the ribs, you can definitely do some soft tissue stuff for that. We want to make sure that that's okay. And then making sure that between the rib and the thoracic spine, as well as between the rib and the sternum, that there's good motion between those joints. So our manual therapy is really focusing on that. So I kind of mentioned this with phase 2. But we're definitely going to be checking, because remember, the rib is healed at this point. This is like the ribs are healing very fast. So you can definitely mobilize at the costosternal junction. You can definitely mobilize at the costovertebral junction. And you're kind of palpating those areas while they're breathing to see if there's anything that's kind of getting stuck. And then you're treating that. You also are going to do a lot of kind of rotation mobility. So you're not just doing things in the sagittal plane, but you're really thinking about the transverse plane at this point. So suggestions would be like chopping exercises, kind of that 3D motion, three-dimensional motion with chops, reverse chops, using resistance for those, and then, thread the needle, cat camel. Cat camel is still in the sagittal plane, but thread the needle is going to be rotation. You're going to, kind of working on getting rotation in sitting, not just quadruped. I love quadruped. Don't get me wrong. I think it's a great position to work on trunk rotation, but also getting that trunk rotation in a functional position, which would be in sitting. You can do some dong tai song dong, mobilization with movement for trunk rotation in sitting. And then as you work on breathing, you can work on doing big movements with the breathing. So we kind of mentioned this earlier, but doing like trunk extension with inspiration and flexion with expiration. And then you can also start adding arm movement. So sometimes, depending on where the fractures of the ribs are, you may find that they're scared to move their arms, especially overhead. So remember, scapula is moving along the thorax, meaning the ribs. And so if there was enough rib irritability, they may be fearful of lifting their arms up. So hopefully you're recognizing whether or not they could raise their arm up, and you're seeing that early in rehab. And so as you get into these later phases, you can basically combine the breathing with arm movement. So you can do inspiration and then raise the arms up into flexion, abduction. You could do external rotation of the shoulders and breathe in. And I'm sure you guys can probably picture me. I'm doing it right now. I'm such a dork. I'm doing external rotation and breathing in. And then as you go into expiration, you can do shoulder extension, adduction, internal rotation. And then the last suggestion is actually using eye, so kind of like looking up with inspiration, looking down with expiration. So these different movements to help, again, kind of stimulate and allow the ribs to do their job better. So again, rib fractures and rib injuries, when you see them, it's kind of different. So just recognize the importance of making sure they can breathe correctly, make sure they don't have pain initially with coughing, and then playing with mobilization of joints and keeping them mobile really throughout, because the ribs are going to heal very fast. The pain should really just be occurring in the first week or so. So you should be able to move relatively quickly through rehabilitation with these patients.